Clinical Focus with Manda and Ben. Bringing you weekly reports on clinical anatomy. Welcome to week 3, guys. We've got Manda here with me today.
Hello, guys.
And today we're going to be talking about the second part of clinical anatomy of the thorax, so going into a few details about that. We've got a pretty exciting show lined up with plenty of clinical applications and relevance, and that kind of leads me into my next little bit of segue, which is that we've got a few interesting shows lined up for you in future as well. So we invite you to get onto the Facebook group, www.facebook.com/clinicalfocus, and send us an email at clinicalfocus@gmail.com if you've got any ideas, feedback, suggestions, or you want to get involved yourself. So yeah, we encourage you to do that. So today we're starting with talking about the ribs and the skeleton. So we're going to be talking about rib fractures. So Amanda, tell me what you know a bit about that.
Well, we start with mentioning ribs 1 and 2, and they are usually well protected by the clavicle. So it's very rare to see fractures of these two ribs, because usually they are, again, well protected. And if you see fractures on an x-ray of the first or second ribs, this usually indicates severe trauma to the root of the neck and the upper thorax, which is an emergency. Similarly, the last two ribs 11 and 12, because of they are flail ribs, so they are not attached to the sternum anteriorly, so it's very rare to see any fractures of these two ribs. Now, usually ribs fractures just slightly anterior to the region of the angle, because it's the weakest point there, and the angle is the point of greatest curvature, and this predisposes the ribs to fractures at this point.
Okay, so one of the issues we can have with rib fractures is if we get to a point where we have multiple ribs fractured, and that's a condition called flail chest, which is seen in the anterior or lateral chest wall, and it's where you get kind of a paradoxical movement of the ribs. So on inspiration, you get the ribs moving inwards in a certain section where you've got the fracture, and on expiration, you've got it moving out. Now, this is an extremely painful condition, as you can imagine, and
exactly, and the way to fix that is actually to use clips or wires to fix that fractured segment of the chest wall. Otherwise, if you keep it like this, it's, as you mentioned, it's very painful, and it can cause damage to some internal organs, like the lungs, for example.
And that's in contrast to how you repair just a normal single rib fracture, which involves...
Usually you don't use any surgical procedures to fix that, because ribs, they have a high degree of self-healing, so there's self or auto-ossification, so the two fractured segments, they usually heal pretty well.
And there's a lot of flat muscles in there that tend to hold the ribs in their place that they should be in.
Exactly. Now, let's remember that in children, the ribs and the costal cartilages are more flexible than that in adults. And for this reason, if you have blunt trauma in a child, this might cause damage to some thoracic organs without fracturing any ribs. So you need to just be mindful of that. Now, let's talk about abnormal ribs, specifically a cervical rib. Now, a cervical rib is a rib that is in the neck region. And usually, as we know, the ribs, they are in the thoracic region only. But if you have a rib in the cervical region, this is unusual, but it's quite common, actually. This abnormal rib can compress the subclavian artery and vein, and it can impinge on the inferior trunk of the brachial plexus as these structures pass between the middle and the anterior scalene muscles. And this condition, the compression of these structures by a cervical rib, is known as a thoracic outlet syndrome. And as this syndrome is presented as numbness and tingling in the upper limb, and this can mimic a cervical disc problem. Now, for example, other causes of thoracic outlet syndrome might include hypertrophied scalene muscles or abnormal fibrous band, but the most common is the cervical rib.
So you mentioned the cervical rib, and the technical name for that is the supranumeracy ribs, where you have extra ribs. Now you said it was relatively common, and the literature I have here mentions that it can be up to 2% of people, which is quite significant. 1 in 50 people may have this rib. And in terms of not having any clinical pathology, maybe one of the significant things is you've got to consider this when you're counting ribs and analysing positions in the chest. If the person has another rib in the C7 vertebrae or coming off a C7 vertebrae, it's worth considering that. Digressing a little bit here, but if we go on to the sternum and the kind of ossification and formation of the sternum, there are some clinically important things here. We could talk about the sternal foramen, which is where we have an incomplete ossification of the sternum on the anterior part, and this leaves kind of like a bullet hole in the sternum, and that can be mistaken on a radiograph for actually being a bullet hole, and that's something to consider when looking at the sternum.
Exactly. Now, another surgical application of the sternum is that we split the sternum in the midline into two halves, and then these two halves are retracted away from each other during surgery. And this procedure is called sternotomy. And we do it usually if we want to get access to the thorax to do some heart-related surgery, or to, like for example, CABG, coronary artery bypass grafting. They usually do it this way, or if there's a surgery that involves other thoracic organs.
So, you've talked about a median sternotomy, the cut down the sagittal plane, the median sagittal plane.
Mm-hmm.
Why would you do this as opposed to doing a transverse cut along the thorax?
Well, I suppose it provides convenient access to the thoracic cavity. And of course, the sternum is rich of bone marrow, and it heals very conveniently, very beautifully. After you finish the surgery, the two halves of the thoracic cage, they are wired back together. And this is also another important finding. If you look at an X-ray of a patient, it's very important to comment on any wires or any clips you see, which might indicate sternotomy. And also during the examination of the cardiovascular or the respiratory system, while during the general inspection part of the examination, you comment on any scars.
Yeah, which leads me into my next part. When you are looking at the clinical features of a patient who's come in for a respiratory examination or even a cardiovascular examination, you've got to comment on the chest specifically. And one of the things you might notice is that the patient might have a pectus excavatum, which is otherwise known as a funnel chest commonly, or on the other hand, you might have a pectus cavernatum, which is known commonly as the pigeon breast. And what these are is the pectus excavatum is a projection of the I apologize. Yeah, pectus excavatum is a residual kind of part of the chest where it's concave inwards, whereas the pectus cavernatum is where you've got the projection outwards.
That's right. And with pectus excavatum, usually, if it's so severe, it can actually compromise the respiratory and the circulatory functions, because you have the sternum, which is sort of, as you mentioned, concave inwards, so it pushes against the heart or the trachea, or even the trachea. Now, let's talk about the sternal angle. Sternal angle is a very important region in the chest, and all of us should know about it. Now, the sternal angle, or the angle of Louis, is actually a plane that passes through the sternal angle, or the manubriosternal joint anteriorly, and the level between the fourth and the fifth thoracic vertebrae posteriorly. Now, clinical application of that during examination is very important to count ribs, and the proper way to do it is to identify the sternal angle, and then the sternal angle corresponds to the level of the second intercostal cartilage, and from there you can actually count the ribs down, starting from the second intercostal space below the second costal cartilage. We have a lot of events that happen at this level. By the way, this level, the sternal angle, is the division line between the superior mediastinum superiorly and the inferior mediastinum inferiorly. Now, as we mentioned, there are a lot of structures or events happen there. and we can summarize them in a mnemonic. It's called the patella, Patella. Now the first P stands for passage of thoracic duct to the left. Now we know that the thoracic duct is the major lymphatic passage of lymph from all structures below the diaphragm, as well as the left upper half of the body. This thoracic duct, it passes from the right to the left at the level of the sternal angle. The A stands for the angle of Louis, which is again corresponds to the second costal cartilage and the manubriosternal joint. Now this joint, given it's in the midline, it's if I ask you a question like what type of joint is that, you would say is the secondary cartilaginous joint, because all joints that are located in the midline are of this type. Another event, T stands for tracheal bifurcation, and we talked about this last week. We mentioned that the trachea divides into the two main bronchi, the right and left, and this level, and the right is more vertical and slightly wider. That's why foreign objects stick there. The E stands for the ends of the aortic arch, so the aortic arch starts and ends at this level. The L stands for the ligamentum arteriosum, and we touched on this last time. We talked as a remnant of the ductus arteriosus during embryological development. It has no function in the adult, apart from it indicates the location of the left recurrent laryngeal nerve, as it hooks just below the arch of the aorta, which is the second L actually. The second L stands for loop of the left recurrent laryngeal nerve. It's a very, very important nerve. And given the fact that this nerve is actually located in the thorax, unlike the right recurrent laryngeal nerve, which is more superiorly, so this nerve is more, it's vulnerable to damage if we do any surgeries in the thoracic region, because of its close relationship to the arch of the aorta and the major vessels in the thorax. And the last A in the patella mnemonic stands for the azygos vein, and the azygos vein actually ends or terminates at this level by emptying in the superior vena cava. So make sure to remember these events.
Okay, so that's just a list of events that are important. I mean, obviously there are many more events that occur at this angle, but if you can remember the mnemonic patella, you're actually doing pretty well, and you can describe any of the significant things that can happen. That leads us into kind of where we're going to go next, which is talking about the intercostal areas.
Now, we mentioned this last time, the intercostal space, it has some structures in it, and we need to know about these structures. Now, there's a mnemonic VAN, V-A-N. V stands for vein, A for artery, and N for nerve. So these are the intercostal structures: intercostal vein, intercostal artery, and intercostal nerve, from superior to inferior in the intercostal space. Now, some clinical applications of that
is to look at what happens if we're doing something like a nerve block, where we've got to consider where we put the needle for this, and we know that the nerve is the most inferior part of this group. So what would that?
Okay, so to block an intercostal nerve, a procedure called intercostal nerve block, so the needle is usually inserted near the inferior border of the rib superior to the intercostal nerve. Now, if you contrast that to another procedure, if we want to put a chest tube, to drain a fluid in the pleural cavity, for example, or if we want to insert a needle to take a biopsy from the lung. In this case, we try to avoid any damage to the nerve or the other intercostal structures. So we usually insert the needle or the tube near the superior border of the rib, inferior to the intercostal space.
Okay, so we've considered the collateral supply as well as the normal supply, but we've got to consider the fact that in the thoracic region and in some of the abdominal region as well, we've got significant overlap in the dermatomes of these nerves. So that means that to have effective nerve block, we actually have to do at least 2 or more to have any significant anesthetic effect.
That's right. Now the next topic is shingles. Now, shingles is usually a reactivation of a previous infection by varicella zoster virus. Usually children, they have chicken pox, and it's caused by varicella zoster virus, and the virus travels all the way and goes all the way to the posterior root ganglion, which is a sensory ganglion. So the virus stays there, enjoying the peace and sleeping, no problems at all, and stays dormant there for quite, depends. It stays for years.
It can stay for many decades even. You can come back in late life with this infection.
Exactly, that's true. So the virus is waiting there for an opportunity to reinfect the human body, and it depends. So you might have another infection that trigger the reactivation of the varicella zoster virus. The patient might be immunocompromised or very old. So whatever the reason, shingles again is a reactivation of that virus. So the virus starts traveling from the dorsal root ganglion all the way to the dermatomal distribution of that particular sensory nerve.
So what can you tell us about the pain or what we can see clinically regarding this condition?
Yep, so the pain is usually very sharp pain, sort of a burning sensation on the skin, and it has a dermatomal distribution, and it does not cross the midline. That's a key feature that you need to recognize. Now, the pain usually starts first, and then these eruptions, red, painful eruptions, they come later in the course of the infection.
And what they usually say is, if you notice the pain on the dermatomal distribution, and if you've noticed it, you've got about 2-3 days before you start seeing the activation of a rash, any sort of vesicles that have full of exudate and pus and whatever. And if you can kind of get the antivirals going in this period before the rash comes up, you've got a pretty good chance of actually being able to suppress the infection from clinically becoming quite a severe case of infection.
That's right. Now, the reason that we mentioned this here in the thorax, because it's one of the causes of chest pain, sharp chest pain, and you need to differentiate this from cardiac causes of chest pain. Now, even if some people with shingles, when you treat them, the pain goes away. But with other patients, actually the pain persists for months or even years, and this condition is called post-herpetic neuralgia. And even simple touch to the skin can trigger severe pain, and this is a serious condition.
Okay, so that kind of concludes the first half of what we're going to be doing today. So we're back to talk a little bit about the lungs briefly, and then we're going to move into mediastinum.
I guess the most important thing to talk about is lung cancer. And there's a specific type of lung tumor to talk about. It's called the tumor of the apex of the lungs, also known as Pancoast tumor. And this tumor may involve the sympathetic chain and interrupt sympathetic innervation to the head and neck, producing what's known as Horner's syndrome. Now let's talk a little bit about Horner's syndrome. It's not related to the thorax, it's more of like head and neck anatomy, but it's quite relevant here because one of the causes of Horner's syndrome is Pancoast tumor. Now Horner's syndrome is actually when you have ipsilateral anhidrosis, meiosis, and ptosis. Now what is anhidrosis? Anhidrosis is when you don't have any sweating. So there's no sweating on one side of the face. Meiosis refers to the pinpoint constriction of the pupils. And ptosis, starts with a silent P, refers to the dropping of the upper eyelids. So you have a patient with ipsilateral, no sweating in his face, and you have a dropping of the upper eyelid, and you have constriction of the pupil. So you think of Horner's syndrome, and if the patient is a heavy smoker, you might as well consider Pancoast tumor or tumor of the apex of the lung as a cause of this Horner's syndrome. Now, this leads me to another topic, which is pneumothorax. Now, pneumothorax is the presence of air in the pleural cavity, and we touched on this last time. We mentioned that usually the pleural space, we have the parietal pleura and the visceral pleura, and between them there's no air, but there's a small amount of fluid to facilitate the movement of the two, layers on each other. Now, pneumothorax, there are two main types. We have the spontaneous pneumothorax, which again can be divided into primary and secondary, and then we have tension pneumothorax, which is a more severe life-threatening condition. Now, with the spontaneous pneumothorax, what happens is that the lung, let's talk about primary spontaneous pneumothorax first. Now, with the primary usually happens without no underlying lung pathology. So the lungs are normal, but for one reason or another, the lung is covered with small blebs, and one of these blebs might rupture, and as a result, you have a spontaneous pneumothorax.
And this condition will occur in tall, thin males, more common Caucasian males, and it's especially common in individuals with Marfan syndrome.
Exactly. So, for example, a scenario in the exam might be a tall, young male. He's a basketball player, and suddenly he developed a severe shortness of breath, and he was brought to the emergency, and they took a chest X-ray. They might show you the chest X-ray in the exam, so you need to recognize that this is a classical presentation of a spontaneous pneumothorax.
And how would you recognize that with an X-ray?
Now, that's a very good question. Usually, you see a black region, which indicates the pleural cavity full of air, and you see the collapsed lung on one side only.
And the one of the main indicators to look for to tell you that it's a spontaneous pneumothorax is that you've got a pencil-thin line that runs down the boundary of where this is occurring. Now, in most cases of a primary spontaneous pneumothorax, it will heal itself, but when you've got a condition where you've got the oxygenation in the blood lowering, or you've got a very severe percentage of the lung that's been collapsed, then you've got to look at doing some sort of chest drainage to get that air out of the space. Now that leads us into the secondary spontaneous pneumothorax, which is where you have some sort of underlying disease that's caused the lung to rupture in some way. And once again, the treatment for that would be to usually let it heal itself. In some conditions where it's more severe, you might have to look at draining the air out of the pleural space. But the other important thing is to look at the underlying cause and look at treating that, because that's obviously an enormous risk factor for it occurring again, as well as being an enormous risk factor for any other conditions of the lungs.
Yep, so COPD is one lung pathology that might cause secondary spontaneous pneumothorax. Now, with tension pneumothorax, as I mentioned earlier, it's a life-threatening condition, so in which there's the air enters the pleural cavity during inspiration due to a penetrating wound, but cannot exit during expiration. So the wound behaves like a one-way valve, so the air enters the pleural cavity but cannot escape. Now, as the air pressure increases on the affected side of the thorax, there will be a mediastinal shift. So the whole mediastinum, you would expect including the trachea, the heart, will be pushed to the other side, and this actually compromises the respiratory and the circulatory function. So the patient might present with chest pain and dyspnea. You might also notice jugular venous distension and a tracheal shift develop as the pressure increases.
And we have to notice that the tracheal shift is away from the affected side, not towards it. So that indicates that if the tracheal shift is to the left side of the patient, that we've got, now it may not be a tension pneumothorax, but in the case of a tension pneumothorax, that the tension pneumothorax is on the right side of the chest. Okay, so that leads us away from the lungs. We just wanted to recap that a little bit from last week and go over a bit more of the pneumothorax condition, which is actually quite common. But that we're going to leave that now and talk a little bit about the mediastinum. Now, the mediastinum they're different regions in the chest, and they're divided kind of as a theoretical concept. So we've got the two main divisions, superior and inferior mediastinum, and they are divided, and we touched on it in the first half, by the kind of plane through the sternal angle. So that goes through the manubriosternal joint and to about the level of T4-5 at the back. And that's kind of a theoretical plane. There's no nice little plane that you can dissect through there and find a very clean division, but that's kind of how we divide it up. And now the superior mediastinum is the region between the thoracic aperture and that plane, and the inferior mediastinum is a little bit more tricky, but we can divide it up into the anterior, the middle, and the posterior part. Now there are a few things to mention here. We'll talk a bit about the superior mediastinum first. There's a whole range of contents that are in this that we should kind of consider. We've got several viscera, so we've got the esophagus, the trachea, and the thymus.
Yeah, and with the thymus, usually the thymus is well developed during infancy, but as we grow, the thymus actually involutes and it shrinks in size, and it becomes, in an old person, it's no more than a small piece of tissue, fatty, fibrous tissue. But the clinical application of the superior mediastinum here that we can mention is during thyroid gland examination, which is a very important examination. So if a patient presents with goiter, which is a sort of a swelling in the neck region, you want to make sure that the goiter is not growing inferiorly all the way to the superior mediastinum, all the way behind the sternum. It's called a retrosternal goiter. So a good way to check for that is to percuss the upper sternum, checking for any retrosternal goiter.
Okay, so just recapping, so we have three viscera there, the esophagus, the trachea, and the thymus. This is in the superior mediastinum. We've also got a series of arteries. So we've got the arch of the aorta, and we've got some significant branches of the arch of the aorta. We've got the brachiocephalic trunk, which goes off to the right. Now, the brachiocephalic artery, which is the brachiocephalic trunk, is only on the right. On the left, we instead have the left common carotid and the left subclavian artery coming off. Now, the right brachiocephalic artery on the right side, that divides then into the right common carotid and the right subclavian, and that's kind of an interesting thing to kind of consider when we're dissecting out this part of the body, or even performing surgery on this part of the body. Now we have a series of veins. We've got the superior vena cava, the arch of the azygos vein, the brachiocephalic veins, of which we have two this time rather than just one. We've got the inferior thyroid vein and the left superior intercostal vein, not the right one in the superior mediastinum. We've got a few lymph vessels, just the thoracic duct, some bronchomediastinal lymph trunks. We've got some paratracheal lymph nodes which run along the inferior part of the trachea, just along the sides of it. And we've got some superior tracheobronchial lymph nodes which just sit above the carene here, just along the sides of it. Lymph node here, just along the sides of it. Above the carene here, just along the sides of it. Lymph node above the carene here, just along the sides of it. Lymph node above the carene here, just along the sides of it. Lymph node above the carene here, just along the sides of it. Lymph node here, just along the sides of it. Above the carene here, just along the sides of it. Above the carene here, just along the sides of it. Above the carene here, just along the sides of it. Above the carene here, just along the sides of it. Above the carene here, just along the sides of it. Above the carene here, just along the sides of it. Above the carene here, just along the sides of it. Above the carene lymph node here, just along the sides of it. Above the carene lymph node here, just along the sides of it. Above the carene lymph node here, just along the sides of it. Above the carene lymph node here, just along the sides of it. Above the carene lymph node here, just along the sides of it. Above the carene lymph node here, just along the sides of it. Above the carene lymph node here, just along the sides of it. Above the carene lymph node here, just along the sides of it, above the carene, lymph node, above the carene here, just along the sides of it, above the carene here, just along the sides of it, above the carene here, just along the sides of it, above the carene here, just along the sides of it, above the carene, lymph node here, just along the sides of it, above the carene, lymph node, above the carene here, just along the sides of it, lymph node, above the carene here, just along the sides of it, above the carene, lymph node, above the carene here, just along the sides of it, lymph node, above the carene here, just along the sides of it, above the carene, lymph node, above the carene sides of it, 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 lymph node, above the carene sides of it, lymph node, sides of it, above the carene, lymph node, sides of it, above the carene, lymph node, above the carene, sides of it, above the carene, sides of it, above the carene, lymph node, above the carene, sides of it, lymph node, above the carene, sides of it, above the carene, lymph node, sides of it, lymph node, above the carene, sides of it, lymph node, above the carene, sides of it, sides of it, above the carene, lymph node, sides of it, above the carene, lymph node, above the carene, sides of it, lymph node, above the carene, sides of it, above the carene, sides of it, lymph node, sides of it, above the carene, 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 lymph node, above the carene, sides of it, above the carene, lymph node, sides of it, above the carene, lymph node, sides of it, sides of it, lymph node, sides of it, sides of it, lymph node, sides of it, lymph node, sides of it, lymph node, lymph node, sides of it, sides of it, lymph node, 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 sides of it,